the biggest challenge in implementing risk stratification models, I think one initially is really the technical challenges that it presents, in that you are trying to collate data from a number of different sources. And it's getting the buy-in, quite often a political buy-in, that's a worthwhile thing to do. And particularly for the sorts of models I'm working with, I'm trying to get a complete pattern of data related to an individual. So I want to have a complete picture of what is happening to that individual within a community, within the hospital system, within the GP system over a year. And it's getting all those systems to work together. And of course, there's no single data sharing agreements in those. In fact, there's still legal issues over disputes over who owns the data. I think that, to me, the biggest challenge, I mean, you can tell I'm from the UK, but I work with the US model in the Hopkins model. Now, what was interesting to me when I first approached the Hopkins, in fact, I first learned about it probably over 20 years ago, was whether it was generalisable. In what sense is it generalisable to our data? So is it taking into account specific nuances of data that you only find in the US? And it's something I found attractive in the system, in that it didn't approach it in that way. It sought to classify patients according to their health needs, which is something that's immediately transferable. So one thing is how specific to certain data items. So if you need a very specific ICD-10 code of heart failure, and that's the only way you're ever going to get that risk variable, then that's a definite problem. But if you have a system that's much more comprehensive and looks at the whole concept of heart failure and its relatedness to other conditions, then it's far more generalisable. But also the ability to have a more open system that you can adapt on the fly and also to recalibrate that system reasonably easily. It's looking at what data is available. There's always this catch-22. To be cost effective, you'll use routine data that you normally collect. And part of it at the moment, still in the NHS, is realising what data's out there. If we only concentrate on hospitals, which is where we've got our data set already, we have SUS, we have a central data set, we are making all our health systems based on 5% of the population. And they're a very rarefied population. Yes, they're consuming 30 to 40% of the cost. But the fact is we're making all our health decisions based on those data. So we're not, again, to use my previous answer, it's not generalisable, and we're not looking at the population. And while we can firefight problems, like looking at repeat admissions, frequent flyers as they used to get called, we're missing the chance to do more preventative care by understanding the issues in the wider community for patients who yet haven't come in contact with the hospital. And that's the data we can miss if we don't then exploit GP data in particular. Now, the other issue is whether we can take on other data. I think we really have to view that as we go along. Personal level data is far more valuable, but it's also more costly to collect. So again, it's that trade-off between what data have we got, what can we make reasonable efforts to obtain, and then to utilise and to make that useful. So it's really concentrating again on the objectives of what the Commissioning Board wants to do as well. I think it provides a huge opportunity, because now you have a body in theory responsible for a whole population in terms of all of their health outlets. So that provides a huge opportunity. However, it is this issue of putting up GPs in particular and their concerns that they're trained as physicians, not trained as risk managers of a population. So that presents a huge challenge to them to be able to take on that risk and have the, I guess, the necessary skills to commission in that broadest possible sense. And I know a number of GPs, say, well, actually, I know my population very well, and that's great. There's others who say, well, I am here as a primary care consultant first and foremost. And that's the other positive side for me, is the fact that it is primary care orientated.